Hello and welcome to our presentation today. Today we are going to look at beta blockers. These drugs are indicated for two major functions, that is for as an antiarrhythmic and as an antihypertensive. So let's see how it brings about those two effects. Beta blockers are also referred to as beta-adrenergic blockers. They do block beta receptors. Okay, so they block the beta receptors which are here. So once they block, they prevent the catecholamines, that is the epinephrine and norepinephrine, from attaching to these sites, right? To these sites. So beta blockers bind to beta-adrenergic receptors, preventing epinephrine and norepinephrine from occupying these receptor sites on the cell membrane. As you all know, stimulation of beta-1 receptors of the heart normally results in an increase in the heart rate. But by blocking these beta-1 receptors, beta-1 blockers or beta blockers, they decrease the heart rate, and thus they have a negative conotropic effect. Okay, reduction in heart rate will result into this process. Okay. So we also have cardiac contractility, at least reducing. Cardiac workload also reduces, and also oxygen consumption will also reduce, and this will provide stabilizing effects that normally contribute to what we refer to it as antiarrhythmic activity. Equally, beta blockers also suppress the renin production from the renin-angiotensin converting system. All right, so we have here the renin. It's blocked, and when it's blocked, it means we'll have minimal production of angiotensin 2. And this effect, we say it is very beneficial for patients who are hypertensive, because it will prevent the reabsorption of sodium and additional water that are going to increase the blood volume, hence again exacerbating or further increasing the blood pressure. Okay, so this negative conotropic effect, reduction in heart rate, and preventing the catecholamines from attaching to these receptor sites normally stops the sympathetic nervous stimulation. All right. And we have several functions of the sympathetic nervous stimulation. First of all, it's very important in increasing the heart rate for that case. So sympathetic nervous stimulation will lead to release of adrenaline and noradrenaline from these adrenal glands, and which in turn normally increases the heart rate. Also, another effect of the sympathetic nervous stimulation is dilatation of the airways. You find that when the CNS is activated, it will cause bronchodilation, and this will widen the airway in the lungs, which provides for maximum oxygen exchange for that case, and just preparing the body for the flight and fight mode. Also, we have dilatation of the pupils. You find the sympathetic nervous stimulation will cause the pupils of the eye to dilate so that you can see better in a stressful environment, right? That's what we call the mydriasis. Okay. We also have vasoconstriction. So when the sympathetic nervous stimulation is activated, blood vessels in non-essential areas like the GI, the digestive system, the skin are going to constrict so as to direct blood to these vital body organs that will enable survival. We also have mobilization of energy. So under the sympathetic nervous stimulation, this will have the release of glucose from the liver and also fatty acids from the adipose. This is just to prepare your body for the flight and fight mode, all right? And then now we have the suppression of digestion. Okay, digestion is one of the non-essential system at that point. So sympathetic activation will inhibit digestive functions. So this will include gastric motility and secretion of digestive enzymes. All right. Next, we have increased sweating. Sympathetic stimulation will lead to increased sweating and diaphoresis for that case. And we also have the pillow erection. It's also known as the goosebumps. All right. So this is caused by the contraction of the small muscles attached to the hair follicles, and is thought to be a vestigial response in humans, possibly serving a trap, a layer for insulation, or to make an individual appear larger in threatening situations, and this could be one of the defensive mechanisms. So beta receptors are generally found in three types. We have the beta 1 receptor, the beta 2 receptors, and the beta 3 receptors. So beta 1 receptors, we have said they can be found in the heart, especially the cardiac nodal tissue and the cardiac myocytes. We also have the kidneys in the juxtaglomerular apparatus, where stimulation of this will lead to a release of renin, and stimulation of the heart will lead to increase in heart rate. The beta-2 receptors are found in the ciliary muscle and other skeletal muscles, along with the lungs, also the blood vessels, the GIT, the bladder, the uterus, and the liver, right? And this normally enables smooth muscle relaxation. Beta-3 receptors are majorly found in adipose tissues and the bladder, and they also help us at least in the process of the lipolysis, right? Lipolysis. So guys, to remember the beta-1 and beta-2, we normally have one heart, so that's why you should know that beta-1 are found majorly in the heart, while we have two lungs, so beta-2 will be found majorly in the lungs. All right. So we have a number of examples of these drugs, the beta blockers, and we have broadly classified them as cardioselective and non-selective beta blockers. So for the cardioselective, these are drugs that specifically will target the heart. And for us to remember that, we can use the mnemonic, we can use the alphabets, okay, from A to N. This will show all these are the beta cardioselective beta blockers, all right, from A to N. And you can see our N in this case is with E. All right, so examples, we have the atenolol, the bisoprolol, metoprolol, nebivolol, cetirizine, esmolol, the betaxolol, cetimol, talilol, and pratilol. All right, so we could have those are as examples of our cardio-selective beta blockers. On the other hand, the non-selective beta blockers, we could use the alphabet from still N now to Z, and our N here has an A in this case, nadolol. Okay, it's good for you to differentiate between the two, nadolol and nebivolol. Okay, so the E is for the heart. Okay, so these other ones we could have them like the propranolol, the timolol, the carvedilol, labetalol. Labetalol is a unique drug for us because it not only targets the beta receptors, but also targets the alpha receptors for that case. Okay, so we need to keep this one in memory. Okay. Sotalol is also a very unique drug for us to remember. This one is normally given on an empty stomach because food normally decreases its absorption. Okay. Then you have the pintolol, the oxymeprolol, the penolol, and the catalol. Okay. Remember the not even and, but most of these beta blockers, especially the non-selective beta blockers, will be contraindicated in A, B, C, D, where A is the asthma, right? And asthma because they can cause bronchoconstriction. They can also exacerbate the AV blocks, okay, so blocks, and also exacerbate the congestive heart failure symptoms, and sometimes they can mask the signs and symptoms of hypoglycemia, so they may not be so good in treatment of patients with such a conditions, right? Okay, so our prodrug in this category is hydrochloride propranolol hydrochloride. Okay, its therapeutic class, it could be antihypertensive or antiarrhythmia. Okay, but the pharmacological class is the same. It's a non-selective beta blockers. We have several formulations available, ranging from the capsule with the extended release, injections, oral solutions, and even tablets for that case. And it's indicated for several uses, of course. So these drugs are used primarily in treatment of hypertension, right? Hypertension and certain kind of cardiac arrhythmias, such as ventricular arrhythmias, supraventricular arrhythmias for that case. It can also use to decrease the risk of myocardial infarction, right? Myocardial infarction for that case, and also the angina pectoralis. Angina pectoralis. We have already mentioned hypertension, and sometimes with essential the tumors and hypertrophic subaortic stenosis, and also as an adjunctive therapy in patients with tumor of the renal the medulla, right? Okay, fine. We can also use it to prevent migraine and some proliferating infantile hemangiomas for that case. Okay, this drug can be administered as per oral, so you give an immediate release tablets on an empty stomach. You can give extended release capsules consistently with or without food, and food may increase absorption of propranolol. So adherence must be improved by giving this drug either twice or as an extended release capsule. All right. You have to check the blood pressure and the apical pulse before giving. So you hold on patients who are hypertensive and who are having bradycardia, right? Bradycardia, extremes in pulse rate will occur, so we have to withhold. You have to monitor the heart rate and the BP for 2 hours after the first dose when you are increasing the dosages. All right. Okay. So those are some of the prescriptions that you have to take. About the IV intravenous, for direct injection, you have to give it in a large vessel or into the tubing of a free flowing compatible IV solution. Don't give by continuous IV infusion. Drug is compatible with the dextrose, the saline, the lactate solution. So infusion rate, but the infusion rate shouldn't exceed 1 milligram per minute. You need to double check the dose and the route. IV dosages are generally much smaller than the oral. You have to monitor the BP, the ECG, the central venous pressure, the heart rate, the rhythm frequently, especially during IV administration. If this patient develops hypotension, you have to notify the prescriber, and a vasopressor may be prescribed. For an overdose, you give IV isopretrol, IV atropine, or glucagon. Okay, refractory cases may require a pacemaker. So this drug generally reduces cardiac oxygen demand by blocking those catecholamines induced increases in heart rate, BP, and the force of myocardial contraction. We have also indicated that the drug also depresses renin secretion, and this prevents vasodilation of cerebral arteries. Half-life of this drug is about 3 to 6 hours, and 8 hours for the inopran, or the 3 to 6 hours for the imagion. It has several adverse effects. Of course, generally we have orthostatic hypertension for the CVS. We also have the bradycardia, dizziness, vertigo, bronchospasm, especially in those patients who have a history of asthma, hypoglycemia. Patients could also present with nausea and vomiting and diarrhea, Many of these reactions are mild and they disappear with the therapy, but more serious adverse reactions could include things like congestive heart failure, dyspnea, peripheral edema, okay, sometimes, and so that should be looked at in detail. In terms of interaction, this drug could looking at the drug-to-drug interactions, you find that if you're giving the ACE inhibitors, the alpha blockers, the antiarrhythmias, or the calcium channel blockers, you find that they may increase the risk of hypertension when you are co-administering with the propranolol, okay, and these other cardiac effects. So they have to be used together cautiously. When in the case of the aminophylline, I find that aminophylline may antagonize the beta blocking effects of the propranolol. For the cardiac glycosides like the digoxin or digitaxin, they may reduce the positive inotropic effect of the glycoside. So you have to monitor the patient for that clinical effect. Drugs like cimetidine, ciprofloxacin, fluconazole, fluoxetine, paroxetine may inhibit metabolism of propranolol, so you have to watch for increased beta blocking effect. While drugs like dobutamine and isoprenolol, they might decrease the effects of these drugs because dobutamine is a beta-1 agonist. Epinephrine may cause severe vasoconstriction, so you have to monitor the BP and observe the patient carefully. If you are having glucagon may antagonize the effects of propranolol effect. Okay, so they have to be used but they may be therapeutically in emergencies. For the haloperidol, it may cause cardiac arrest, so you have to try and avoid use together. If you're having insulin and oral anti-diabetics, this one may alter the requirements for propranolol in previously stabilized diabetics. So you have to monitor the patient for hypoglycemia. Lidocaine may reduce, in case of lidocaine, propranolol may reduce the clearance of lidocaine, so you have to monitor the lidocaine level closely. While in case of the monoamine oxidase inhibitors and the tricyclic antidepressants, they may increase hypotensive effect, so you have to monitor the effect, the therapy. For the NSAIDs, they may blunt the antihypertensive effect, so you have to monitor the therapy. We also have the phenothiazines like the chlorpromazine, that is CPZ. Okay, it may increase the risk of serious adverse reaction to either drug, so you have to use thiolazidine. We find that the use of the thiolazidine is contraindicated. If chlorpromazine must be used, then you have to monitor the pulse rate and the BP. You have to decrease propranolol dosages as needed. Use of the propafin and the quinidine may increase propranolol levels, so you have to monitor cardiac function and adjust the propranolol dose as needed. Risperidone may increase the risk of hypertension, bradycardia, vertigo, and syncope. Theophylline may decrease, I find that propranolol may decrease theophylline clearance by about 30 to around 52%. So, and this could diminish the bronchodilatory effect of theophylline. So you have to consider the therapy modification. In case of warfarin, it may increase the warfarin level. So a patient who is on this drug, you have to monitor the PT and the INR values. For the herbs, you find that most of these herbs normally decrease the anti-hypertensive effect of propranolol. So you try to discourage the use together. In terms of lifestyle, alcohol use may increase or decrease propranolol level, so you have to discourage alcohol use. Equally, for the smoking, it may decrease propranolol level, and this you have to monitor clinical response and adjust dosages as needed and try to discourage smoking. Generally, propranolol may increase the T4 and BNU or transaminase AL, potassium or LDH levels, and it may decrease the T3 levels and also decrease the granulocyte count. This drug is contraindicated in patients who are who have known hypersensitivity to the drug, the bronchial, like the bronchial asthma, the sinus bradycardia, heart block that are greater than first degree, cardiogenic shock, overt or decompensated heart failure. All right. So this drug should be used cautiously in patients who have DM because the drug normally masks signs and symptoms of hypoglycemia, and they have to be used cautiously in patients with renal insufficiency due to increased risk of hypoglycemia. You try to avoid abrupt withdrawal because this might exacerbate the signs and symptoms of hyperthyroidism, including thyroid storm. In pregnancy, there have been no adequate studies during done during pregnancy, so use only if potential benefit justifies the fetal risk. And this drug is associated with fetal intrauterine fetal retardation, neonatal bradycardia, hypoglycemia, and respiratory depression. If this drug is used during pregnancy, ensure adequate monitoring of the infants is available at birth. This drug has been found to be appearing in human milk, so it has to be used cautiously during breastfeeding. Also, you have to monitor the infants for signs and symptoms of beta blockade and hypoglycemia. As a nurse, you have to know that this drug masks common signs and symptoms of shock and hypoglycemia, so you have to monitor heart rate and BP with more keen. Okay, so it is less effective in lowering blood pressure when used as a monotherapy in patients who are black. So you have to try and see that actually it's not the case here. You have to monitor these patients for expected therapeutic effects, dosage, and therapy adjustment where necessary. Okay, remember you don't need to stop this drug abruptly. Okay, okay. In terms of patient teaching, you have to instruct the patient in safe drug administration. You caution the patient to continue taking this drug as prescribed, even if feeling well, and to promptly report any adverse reaction. You have to advise the patient that propranolol may interfere with the glaucoma screening because this drug has the capability of reducing the intraocular pressure. Teach the patient to skip the hemangial dose if the child is not eating or is vomiting, and you caution the patient not to stop the drug without advice from the prescriber because abrupt stopping can worsen the chest pain or can cause an MI. You advise the patient to avoid smoking and alcohol, and then inform the caregivers of the risk of hypoglycemia, especially children with prolonged physical exertion. So generally, this drug can be used, can be classified therapeutically as an antiarrhythmic or antihypertensive, and it's indicated majorly for hypertension, angina, arrhythmias, MI, cardiomyopathy, alcohol withdrawal, and even anxiety. It works generally by blocking beta-1 and beta-2 adrenergic receptors, thus slowing the heart rate. You have to ensure that you're teaching the patient not to discontinue the drug abruptly, so they have to discontinue them slowly. Make them aware that this drug could mask the signs of hypoglycemia. So it's very important for you to monitor the blood sugars. And then lastly, you need to caution patients who have a history of asthma or other COPD because this drug can potentially cause bronchospasms. Okay, that marks up the end of the presentation, guys. You could look at the description section and attend to the quizzes that could strengthen your understanding and just cement your knowledge on the same. Thank you.